Dr. Bernard Lee, MD, has several publications involving prostate cancer survivors in the men who have sex with men community. Dr. Lee, as a radiation oncologist, has the relevant clinical knowledge of prostate cancer treatment, and being openly gay, the personal knowledge of men who have sex with men's sexual practices and concerns. And without further ado, I will pass it on to Dr. Lee to begin his presentation.
Hello, can you guys hear me? If you can hear me, give me a thumb up. Great. Okay, so my name is Bernard Lee. I'm a radiation oncologist currently working in BC Cancer in Canada. And today's topic is prostate cancer for men who have sex with men. So disclosure is that I'm going to talk about my research study, and I have received funding from Canadian Cancer Society, the Prostate Cancer Canada, and I have also received funding from Canadian Association of Radiation Oncology. So for today's talks, here are the objectives. I want to first go over prostate cancer in general. I'll talk about the prevalence. I'll talk about different treatment modalities. Then I want to switch focus for prostate cancer for men who have sex with men. And then I'll talk about my study, a little bit promotion of my study, and answer any question that you may have at the end. So many of you probably already know this, like what is prostate, where is it? So prostate is located under the bladder in front of the rectum. And as you can see in this picture, the urine would go through the bladder, through the prostate to the urethra, out to the penis. And here is a different view that, as you can see, there's lots of duct that converge into prostate before it's secreted out. Those ducts are actually from the testicle and from the seminal vesicle, because prostate gland itself actually is not related to urinary function. It is more a reproductive organ. It secretes its secretion, the fluid, is constitute about 20–30% of the semen volume. And when you do blood work to measure PSA, which stands for prostate specific antigen, it is actually a protein that help maintain the consistency of the semen. And that's about, oh, actually, interestingly, when you do the, nowadays we don't know whether we do PSA screening or not still, but both prostate gland and prostate cancer secrete PSA. If anything, the prostate cancer secretes potentially less PSA than the regular prostate gland. But because prostate cancer doesn't have a good membrane, like a layer, so the PSA that is secreted leak a little bit more into the bloodstream. And that's how you kind of can tell that the PSA increase, that may be a signal that there is prostate cancer. And then there's other fancy tests to look at different kind of PSA in the bloodstream to increase the PSA measurement accuracy. But before any kind of prostate cancer treatment, PSA, I would still have to say is not a very specific test. But after you get a prostate cancer treatment, it will become quite an important monitoring tool. So that is about the extent of the education that most medical doctors will receive regarding prostate gland. But prostate gland actually is, or you can say the structure around it is an important anatomy for sexual function. And I'll come back to that. So prostate cancer is the most common male-specific cancer. 1 in 8 men will get it. And like I said earlier on, that we really don't know whether you should screen for prostate cancer, whether you should do regular PSA or digital rectal exam. For those that do screening, and if they detect prostate cancer, it is often through asymptomatic PSA elevation. Patients feel completely well, and it's a surprise that they get the cancer diagnosis. And as the cancer progresses, some of the patients can get a little bit more non-specific symptoms like urinary frequency, incomplete voiding, weaker stream. And then some of them may even get blood in the urine or in the semen. But then actually most of the common cause for blood in urine and semen is not prostate cancer, it's other causes. And then some of the patients are more unfortunate that the cancer actually present a presentation has already spread and prostate cancer loves to go to the bone. So those patients will present with bone pain. So based on how the patient present, the clinical examination, PSA, Gleason score, and imaging study, then you categorize the prostate cancer into whether they're curable, and within curable, there's low risk, intermediate risk, and high risk, and then the incurable camp, which is the metastatic disease. So when you get a prostate cancer diagnosis, what do? I like to use an analogy, what I call Operation Family Reunion. So you have an upcoming family reunion, and your main objective is to make your family to like you or like you more. And most people achieve that by buying gift. But my secondary objective is that I don't want to spend that much money. I want to spend as little as possible. So before the family reunion, then you have to gauge the situation. Do my fellow family members love me? If they already love me a lot, then you actually may afford to go to the family reunion and empty-handed. You don't need to do anything because they still love you. You may down the road, you may need to buy a gift or two, but for now, you're okay. Versus if your family members already really hate you to the core, doesn't matter what present you buy them, they're still going to hate you. Then at that point, spending money is of no point. If it is in the middle pack, it's like some love me, some don't love me. You may want to buy a big present, a small present, or buy one present in the middle of the reunion, buy another one, and you don't know whether that's the right thing to do. So for prostate cancer, if you catch it early stage, it's a very benign disease, slow growing. It's like the family already love you. You don't really need to do anything at this point. You can afford to just watch. So the active surveillance, down the road, you may need treatment, but that's in the future. So you can save your money for now. You don't have to experience any side effect. Versus if the cancer already presented very aggressively, that has spread everywhere, and cure is not achievable, then you may not want to pursue any aggressive treatment, or if you pursue treatment, you may choose something less aggressive, or you may simply be starting on hormone alone. In the middle pack, when you have the intermediate risk, high risk, is when you start to think about, okay, how aggressive do I want my treatment to be and what treatment I can pick? And it's actually very personalized because let's say you're a long distance truck driver, you do lots of heavy lifting, having urinary incontinence after surgery is completely unacceptable. Or some patient would already have a baseline diarrhea, have like irritable bowel syndrome or other diseases that actually contraindicated for having radiation, then they may pick surgery. So it needs to be discussed very carefully before the treatment, depending on the patient need. But there is actually a recent study published that showed that many patients regret their treatment choice. About 10% of the patients do. More so if they have low risk and they decide to act on it. If they have a low risk prostate cancer, they can afford to wait, but they actually pick surgery or radiation versus active surveillance, they regret more. And when they do more analysis, it seems that the people pick surgery instead of picking radiation regret even more compared to the active surveillance. And many studies have shown that the main treatment regret is sexual dysfunction, which is very understandable because when someone gets a diagnosis of cancer, the first instinct is to beat this cancer, is to survive. They will want the treatment as soon as possible. And sexual dysfunction somehow is put to the wayside. They may not listen to it, or the physician didn't talk about it. And then only after the treatment that, okay, treatment is successful, but what about how I'm living right now? Then suddenly they realize that there's impact on the treatment on their daily life. And there have been studies that show that the better a physician in preparing the patient before the treatment, the less regret they will have. So that's very important when you get a diagnosis. You talk to your oncologist, your surgeon very thoroughly, think carefully, and know what to expect so you can cope a little bit better. So that's transition to the importance of quality of life, because I always tell patients that like controlling your cancer is only part of the treatment. How you live, how well you live is the second part. And you may argue that for prostate cancer, because the cancer, some of them can have very long prostate cancer specific survival, that how they live, the survivorship is even more important. Now, when you want to ask about quality of life, you cannot just go up to a patient and say, are you satisfied with your prostate cancer treatment? Are you having a good life? Are you having a good day? You cannot ask questions like that, because the way you ask questions, the wording you use, the choices you give the patient, even the layout of the question in front of the patient can change the response. So just like when you do any kind of measurement, like for length, you have centimeter and meter, for weight, you have kilogram. For quality of life, you need a specific ruler, a measuring tool, and that's called a validated questionnaire. It is very population specific. So you cannot use a lung cancer questionnaire to give you the prostate cancer. And the same token, you cannot give a questionnaire that's designed for straight men or heterosexual men and give it to men who have sex with men and say this is valid. It doesn't work like that. But here comes the tricky part. For the longest time and even till now, the men who have sex with men community is quite cautious when they're dealing with medical professional. And you cannot blame them, because if you're 18 when Stonewall happened, right now you're in your 70s. This is very vivid memory for them. And back then, it is true that when they disclose their orientation, they would get inferior treatment. They would be discriminated against. So they grow up, they age knowing that, or feeling that they cannot disclose, be honest with medical professional. Things have changed a lot thanks to my predecessor that has been so active to promote rights. So nowadays, I'm a gay man. But I have to say, even in medical school, I have experienced my share of homophobia. And just 2 weeks ago, there's shooting in Colorado again. And so you can understand why men who have sex with men are not comfortable to coming out to the physician. That's lead to the result that many physicians actually do not know they have gay men or bisexual men or men who have sex with men in their practice. And I have some of my more senior radiation oncologists. I asked them, do you have any patient you can refer to me for my study? To say, I don't have any gay men in my practice. But I'll say, you have treated over 2,000 prostate cancer. You're telling me none of them are gay. So they actually do not know. So for the longest time, the medical community assumed that all the prostate cancer patients are heterosexual, and all the sex that they have is penile or vaginal intercourse. There's no other sexual behavior. So there has not been any major study that been done on men who have sex with men. So without this measurement, you cannot monitor the side effect. You cannot compare treatment. You cannot even design any support group survivorship program to see whether it's effective. And like I said, like sexual dysfunction is a major part of regret. So without this, how are we going to improve that? So now you have noticed that I used the term men who have sex with men. So what exactly do I mean? I have to admit, I'm getting old now. So when I'm growing up, is LGBTQ. Then now there is more acronyms added behind it, and I honestly cannot explain them or keep track of them, and it's very hard to standardize, to design any study to incorporate all of this ever-changing sexual orientation and gender identity, which is a good thing, but for study is difficult. So the term men who have sex with men is a term adopted by a Center of Disease Control. Is take away the straight, gay, bisexual. If you identify as a straight man, but you have sex with men from time to time, you're still a straight man, but you're also a man who have sex with men. So the main focus is on your sexual practice. Okay. So, and I'm going to talk a little bit about my study now. And I'll come back to prostate cancer in men who have sex with men just a little bit. So this is kind of for fun. Like for prostate cancer, there's a well-known questionnaire called EPIC. It stands for Expanded Prostate Cancer Index Composite. where the cancer go in this abbreviation, I did not know, but they make a fancy name called EPIC, and many important systemic treatment trial for prostate cancer have very catchy name like Stampede and Charted. It is important that they have this kind of name because it's good it's easier for patients, for researchers to remember. It's help them recruit and help them get funding. So for my research, it's called COMPASS. It's called the Comprehensive Prostate Cancer Assessment on Sexual Health for Men Who Have Sex with Men. So don't ask me how I come up with this abbreviation, but I can tell you that it worked because I have recruited patients and I have got funding. So the goal of my research is to develop a good questionnaire that can be used for prostate cancer a population for men who have sex with men, and it is a very vigorous stepwise process. So I started out the study by interviewing men who have sex with men that has been afflicted with prostate cancer. We pay special attention on their sexual quality of life. And then after that, we summarize the interview data to generate a list of questions that can be relevant. Now, but because I'm a researcher and my fellow collaborators are also researchers, the vocabulary that we pick may not be very friendly or comprehensive. So this questionnaire has actually been reviewed by healthy gay men to make sure they're understandable. And then this questionnaire has been tested with over 200 men who have sex with men with prostate cancer, and to show that the question itself in the questionnaire are functioning well as a group. So what do I mean by functioning as a group? So this questionnaire is divided into different sections. We ask about sex drive, ejaculation, erection, orgasm, some general sexual question that is, you may argue, that is shared by both heterosexual and men who have sex with men. And then we dive into more detail in the practice that more relevant for men who have sex with men, receptive anal intercourse, insertive anal intercourse, because that is related to with your prostate gland removed, with your rectum radiated, would that affect your sexual function? Whether you can do it, whether you enjoy it. And then you also need to ask about masturbation, both solo and receiving, because that's a common sexual activity as well as oral sex. And we also want to find out how prostate cancer treatment affect your relationship, because unlike the heteronormative wife-husband situation for men who have sex with men or gay bisexual men, the relationship status is a little bit more fluid. So we separate into sex with regular partner, like more in a monogamous relationship, versus the other one is sex with a casual partner. We have a special section on urinary incontinence, but we don't just ask pads usage, because for patients that have incontinence, it does affect sexual activity greatly, because when they get aroused, when they reach climax, there can be urine, and it can be quite troublesome, let's just say. So we are at the very last step of this questionnaire generation. We're recruiting patients. We're hoping to have more patients who have history having sex with men between the age of 40 and 75 years old, and have a history of non-metastatic prostate cancer, so they're not on any new agent or chemotherapy. And here is our poster. As you can see, we designed the poster to make sure that it is very friendly to the community. And I have a link at the end of the research, the presentation. I hope Rochelle can share it with the group. And my last bit, my last few words for this presentation is that it has been a privilege as a gay physician that I have a chance to talk to other gay and bisexual men with prostate cancer, interview them, listen to their story. And what I noticed is that unlike HIV, so back then when there's the HIV is affected lots of gay men, but somehow it band them together, give them a voice together, and that's lead to lots of activism and progress. And I'm thankful for their effort again. But for prostate cancer, it's very different because it affects a man's sexual function, and many gay bisexual men is too embarrassed and ashamed to talk to any of their close friend and family. When they go to a support group, all they see is patient with their wife, and the oncologist and the surgeon ask them, "Oh, you're coming by yourself? Where's your wife?" And suddenly they feel like, okay, I have no one to talk to, and my physician don't understand me. And sex, besides biology, regular activity, a pleasurable activity, it is also an important way how a gay bisexual man relate to another gay and bisexual man. By changing the sexual function, you actually affect their identity, so they don't quite know who they are anymore. So with all of this, many of the prostate cancer in the LGBT community, many of the patients are very lonely. And at the end of the day, getting a cancer diagnosis is bad enough already. And I don't think any patient should go through this alone. And I think together we can change that. And I hope to change that. Thank you.